Hello, welcome everybody as you pop in from the waiting room. We will start very shortly. We have a lot of people waiting to get in. All right. It's slowed down a little bit. I think the bulk of us are in for the moment. I'm sure we'll be joined by more as we go on. I want to welcome everyone this afternoon. My name is Matt Shepard. I'm going to be moderating this session on Medicare Appeals. Our presenters today are going to be Center for Medicare Advocacy Co-Director David Lipschutz, Senior Attorneys Mary Ashkar and Wey-Wey Kwok, Supervising Attorney Eric Krupa, and Project Manager and Attorney Justin Lalor. The Center for Medicare Advocacy, as I believe the next slide discusses, is a national nonprofit law organization that works to advance comprehensive access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy, all based on the experiences of the real folks who contact the center every day. Before I hand things over to David to get us started, a little Zoom housekeeping for us all. As with any online presentation, your audio and video connectivity are going to be at the whim of your internet connection. We don't have any control over that. But should you have any trouble watching or listening, or maybe you get in and then get kicked out, any of these things can happen. Every registrant is going to receive a link to the recorded presentation in a follow-up email from me. While you're watching, note that on Zoom, if you don't want to see empty boxes of the presenters who aren't currently live on video, you can change that setting in the View menu. For questions and discussion today, please use the Zoom questions button at the bottom of your screen. You can type questions and comments in there, and then I'll pass them on to our presenters. We also have the normal chat feature, as I can see some of you are in, and we'd love to hear who you are, where you're from, what brings you to us today. But for the actual questions, please try to use that questions section because things in the chat, as you might already be seeing, move very fast and things can get overlooked and or lost. I will also be posting a link to today's slides in that chat momentarily, just in case my email from earlier today somehow didn't make it to folks. Thanks once again. I think that's it for me, and I'll hand things over to David Lipschutz to really get us going. David, thanks.
Thank you, Matt, and thanks to all of you for tuning in with us for the next hour and a half. We have a lot of material to get through in order to meet our aim of saving some time for Q&A. Note that we have included far more material in these slides than we will have time to get to, but include them for your future reference. Here's an agenda of what we're going to go over. I'm going to start us off with an overview of appeals. Eric will then talk about traditional Medicare appeals. I will then come back in, talk a little bit about Medicare Advantage appeals. We'll hear from Justin about Part D appeals. Mary will walk us through some appeal tips, including dealing with administrative law judge hearings. And Wey-Wey will close us out with a discussion of a new type of appeal in Medicare regarding hospital observation status. Then we will all get back on and field Q&As. Let me move us on. Anyone who has ever interacted with any form of health coverage knows that sometimes problems arise, and that depending on the problem, there can be different ways to try to address them. Sometimes issues can be resolved informally, such as the correction of a billing code submitted by a provider. Sometimes to resolve issues, you need to pull in folks from Medicare, whether from 1-800-Medicare or people at the Centers for Medicare and Medicaid Services who might need to assist with, for example, enrollment issues or processing special enrollment period requests. As a resource, we include here a paper from the Urban Institute about complaint processes in Medicare or the lack thereof, which outlines some of the ways people try to resolve issues outside of the appeals process. Sometimes, though, it is necessary to submit a formal appeal about which we will spend the balance of our time today. I want to make a few overarching points that will be reiterated and expanded over the course of this webinar. Note that there is a distinct difference between grievances and appeals in Medicare, primarily with respect to Medicare Advantage and Part D. Some types of health insurance coverage outside of Medicare use these terms interchangeably, not so in Medicare. In general, the appeals process is used if benefits, coverage, and costs you pay for a service is at issue. This is what we're focusing on today. Grievances tend to focus on things like Medicare Advantage plans or providers' operations, activities, or behavior. Note that there's a separate process for quality of care complaints through the quality improvement organizations. And note that the outcomes of grievances tend to be less transparent. While Medicare Advantage and Part D plans are supposed to accurately categorize and parse the difference between appeals and grievances, this does not always happen. So it is critical to use the right language and to make sure that your attempted appeal is treated as such and not a grievance. Throughout the appeals process, parts A, B, C, and D, there are standard and expedited appeals with differing timeframes and sometimes different rules, procedures. Some scenarios are treated as expedited or fast appeals automatically, such as discharge or termination of services one is getting in Part A covered settings, namely hospital, skilled nursing, home health, and hospice. Another point to make is that something usually has to happen in order for someone to have an appeal right. There must be a trigger. As Eric will discuss in traditional Medicare, that's often a Medicare summary notice, whereas in Medicare Advantage and Part D, it's a decision by the plan. But beneficiaries in such plans can force the issue. They can request plan decisions that then trigger a right to appeal. After some kind of initial decision is made, there are 5 steps in the Medicare administrative appeals process. Note that the first 2 levels of appeal, the appeal steps have different names and can have different decision makers or actors and different timing depending upon the scenario. For example, in traditional Medicare, Medicare administrative contractors issue decisions in the first level of appeal usually. And with respect to Medicare Advantage and Part D plans, usually the plans themselves make the first decision or first level of review. It can be hard to parse or keep up the different decision makers that can have different names in different parts of the country, but in theory, all of the information one needs to proceed through the appeals process is provided in the notice about decisions that are made at each level. Once you get to the 3rd level of appeal, if you proceed that far, the appeals processes are uniform across the different parts of Medicare, A, B, C, and D. The 3rd level is administrative law judges, which is overseen by the Office of Medicare Hearings and Appeals, or OMHA. Then you have the 4th level, the Departmental Appeals Board, sometimes known as the Medicare Appeals Council, and then very rarely people proceed on to federal court. Note that in these slides, AIC stands for Amount in Controversy. In other words, there has to be an item or service in question that costs or is worth a certain threshold amount in order to have the right to proceed. For ALJ hearings, it's $190 this year and $1,900 for federal court. If someone needs ongoing care services or drugs over the course of a calendar year, such expenses can be combined or aggregated in order to meet this amount in controversy test. A quick note, we are not going to go over this slide, but know that there are some types of appeals that we won't have time to address during this webinar, including appeals or actions to the Social Security Administration, such as requests for equitable relief and what is outlined here, challenges to income-related premiums for Part B and D. Here we provide a good resource from our friends at the Medicare Rights Center that outlines this process. One more point before we touch on some resources and then I turn it over to Eric. There's a lot of uncertainty at the moment with administrative actions at the federal level, including concerning the Federal Department of Health and Human Services, HHS, which oversees the Centers for Medicare and Medicaid Services known as CMS, which runs the Medicare program. Just days ago, we learned about a reorganization of HHS that will lead to the Departmental Appeals Board and the Office of Hearings and Appeals to be housed under the authority of an Assistant Secretary for Enforcement under HHS. At this point in time, it is unclear what this might mean for these 2 offices that administer these stages of Medicare appeals and whether it might impact their independence. In addition, in the midst of significant staff cuts at HHS, which combined with recent resignations and retirements is projected to decrease the HHS workforce by 25%, there are news reports that when it comes to CMS, planned cuts include 200 people from local offices that currently provide oversight of plans and manage casework for the Medicare Advantage enrollees. From where we sit, it's hard to see how this will not have an impact on the resolution of issues outside of the appeals process. Here we leave you with some resources of voluminous resources from our website, as well as resources from the National Center on Law and Elder Rights. However, it looks like their website is undergoing a review based upon certain executive orders. With that, I will turn it over to Eric, who will talk to us about traditional Medicare appeals. Eric.
Great. Thank you, David, and good afternoon, everyone, or I guess good morning if you're joining us from some of the Western time zones. So with this section of the presentation, I'm going to be discussing the basics of beneficiary appeals rights in the context of traditional Medicare. So that's Medicare Part A, hospital insurance, which covers inpatient care in hospitals, skilled nursing facility care, hospice care, some home health care, and then appeals in the context of Part B, which generally covers outpatient services. So I want to note at the outset here that there is a lot to get through. And with these slides, I'm going to be focusing on the procedure rather than the substance of appeals. So Justin and Wey later on may discuss the substance as in what you need to prove in order to be successful with an appeal. Here, I want to spend my time on the procedure, what you need to do in order to appeal, what you need to do in order to initiate the appeals process, and ensure that your appeals are timely along the way. So with that being said, we'll start here with overview of what can be appealed. So a core component of Medicare per statute is that beneficiaries have the right to appeal adverse determinations. In other words, adverse determinations, adverse coverage determinations are subject to an administrative appeals process. This slide breaks down, in the context of traditional Medicare, two categories of appeal. The first is service specific. In the context of a hospital, home health care provider, skilled nursing facility, hospice provider, comprehensive outpatient rehab facility, their decision to terminate services is subject to an expedited appeal. So this is a situation where the beneficiary has been receiving services from one of these providers. Provider decides that they no longer, the beneficiary's service no longer meets Medicare coverage criteria, decides to terminate the service. So this is the expedited appeal that David was mentioning earlier. And that's different from an appeal of Medicare's decision not to cover and pay for services already rendered. This is the standard appeal. So anytime you receive a service or an item, durable medical equipment, stay in a skilled nursing facility, ambulance service, the provider bills for that service or item, Medicare declines to cover and pay for that service, you have the right to appeal that as well. That's the standard appeal. Next slide, please. So standard versus expedited appeals, again, as implied, expedited appeals, they're going to be processed more quickly. And this is the really important distinction. A favorable decision overturns the provider's decision to terminate coverage. So that means whoever's reviewing the decision decides that provider was wrong, termination of coverage should not occur, coverage should continue for the beneficiary. That's distinct from the standard appeal, which can take longer and results in coverage and payment for services already rendered. So again, that's a situation where if you're in a skilled nursing facility, you've already spent days in the skilled nursing facility, the SNF bills for those days, Medicare denies coverage for those days, you appeal seeking coverage and payment for those days. Next slide, please. So again, breaking this down more, starting with expedited appeals, there are different processes based on the setting, and it's distinct if you're in a hospital, or in a skilled nursing facility, home health setting, hospice, or comprehensive outpatient rehab facility setting. I have some citations here to the Code of Federal Regulations, and I just want to mention at this point, 3 most important resources if you're researching these issues, if you're going through the appeals process for yourself or for somebody else: the Code of Federal Regulations, Medicare Benefit Policy Manual, Medicare Claims Processing Manual. All 3 of those resources are free and available online. All you have to do is Google any of them. You can Google these specific sites that I have here on the slide, for example. The first link should be the Code of Federal Regulations online. So all of this information is free and online if you're researching it for yourself or for somebody else. Next slide, please. Expedited hospital appeals. So beneficiaries in the hospital, how do they know that coverage is going to be terminating, that they're going to be discharged, and how do they know that they have the right to appeal that decision? Within this context, the answer to that question is they'll receive what's called an important message from Medicare. This is a Medicare approved form, and it's required to be provided to a beneficiary to alert them that their service is going to be terminating, that they're going to be discharged from the hospital. That form, like other Medicare approved notice forms, has directions for how to appeal. So the advice to a beneficiary in this situation is review your IM, your important notice from Medicare, call the number on that notice. That call and a request to appeal initiates the appeals process. Nothing written has to be submitted in order to initiate the expedited appeals process in the hospital context. Next slide, please. So these next 2 slides outline the timeline for hospital appeals. That important notice, important message from Medicare is required to be provided to the beneficiary within 2 days of admission to the hospital, and then again within 2 days of discharge. So if a beneficiary is set to be discharged on a Tuesday, the notice has to be provided either on the Tuesday, the Monday, or late on the Sunday in order to notify the beneficiary that coverage is going to be ending, that they're going to be discharged from the hospital. The timeline within which the beneficiary must appeal, that's midnight by the day of discharge. So if the notice says coverage is ending Tuesday, you have until 11:59 p.m. on Tuesday to initiate that appeal. Initiating that appeal triggers the hospital's obligation to provide the beneficiary with a more detailed explanation for coverage termination. Typically, the hospital isn't notifying you in the important message from Medicare exactly why coverage is being terminated. In the subsequent notice, you'll receive a better explanation. You'll get this explanation, and then you'll get a decision from the contractor you appeal to within 1 calendar day of your request. So appeal on 11:59 p.m. on Tuesday, you get your decision by 11:59 p.m. on Wednesday. If that decision is unfavorable, you're no longer protected from liability, meaning liability begins to accrue. You can be billed for subsequent days after, for example, that Wednesday. Next slide, please. So you have this unfavorable decision. Hopefully it's favorable. If it's unfavorable, you have until noon of the calendar day following the notification to initiate the next level of appeal, the next contractor appeal in this case. That contractor must issue a decision within 72 hours. And again, during that time, the beneficiary is liable to be billed for those days and hours. If that decision is unfavorable, as David went through before, you can then request an administrative law judge review. I'm going to talk more about that in the context of expedited appeals later, but that's the next step in the appeal process after the 2 contractor levels of appeal. Next slide, please. All right, so expedited appeals outside of the hospital. That's skilled nursing facility, home health care, hospice, and comprehensive outpatient rehab facility appeals. So how to know a provider's terminating coverage in those scenarios? You'll know based on a notice of Medicare non-coverage. Like the important message from Medicare, the notice of Medicare non-coverage is the Medicare approved form notifying the beneficiary that coverage is being terminated and notifying them of what their appeal rights are. Again, that has the number for the contractor to call to initiate the appeals process. calling that number, requesting an appeal initiates the process. Nothing needs to be done in writing at that stage. Next slide, please. So this is the timeline on the next two slides for expedited appeals in these within these settings. Unlike with the IM, the NOMNIC has to be issued at least 2 calendar days before the termination of Medicare covered services. So again, if coverage is going to be terminated on a Tuesday, you've got to receive that notice by Sunday. If you receive it on Monday, then the provider has issued that notice late. Once you receive the notice, say you receive it on a Sunday, you have until noon the day before the effective date of the notice. If coverage is going to be terminated on the Tuesday, you have until noon on Monday to appeal that decision, to initiate the appeal, to the Medicare contractor. That decision, there's a little bit longer of a period within which they have to issue the decision. It's 72 hours. And sorry, I was just reading one of the questions that came up, all good questions. The decision must be issued within 72 hours. And if the QIO decision is unfavorable, again, at that point, financial liability begins to accrue. So you're protected for the first decision, the first appeal level. After that, you're not protected from liability. Next slide, please. So again, process continues. You have another contractor level of appeal. In these contexts, you also have the option to request an extension. So typically that next level of appeal is due noon the calendar day following notification of an unfavorable decision. But in this context, you can request an extension of up to 14 days if you want to submit additional evidence. Without getting into too many details, that could be of benefit where you don't want to wait for an administrative law judge hearing, and you want to make sure your case is as strong as possible going to that next level of contractor appeal. So you do have that right to request up to 14 days to submit additional evidence to the next level contractor in these cases. If that decision is unfavorable, then again, you have the right to request an administrative law judge hearing. Next slide, please. So unlike the first two levels of appeal, the contractor levels, it takes longer to have the ALJ hearing scheduled, even in the expedited context. So that begs the question, is it worth going to an ALJ hearing when I'm not going to have the hearing soon? It could take a month or two to schedule, and I'm going to continue to accrue liability throughout that period. Obviously, that's situation specific, and I can't give overarching advice, but a couple things to consider. The ALJ, in the context of an expedited appeal, is considering whether the decision to terminate services was right. They're not looking at subsequent days, subsequent services provided. If you want the ALJ to review those days, it's best to submit additional records prior to the ALJ hearing. It's also important to note that the ALJ may not have the authority to say Medicare needs to pay for subsequent days, because again, what's at issue is whether that decision was right at the time it was made. So if you're going to an expedited ALJ hearing, you should also be pursuing a standard appeal, which we'll talk about in a second, but a standard appeal to pursue coverage and payment. Another thing to consider, these notices that I've talked about. What if a provider doesn't issue them on time? What if a provider issues them in a way that doesn't allow the beneficiary to understand what their rights are, their appeal rights are? In that case, a provider may be found liable on appeal. It's always important to note when you're appealing, when you receive the notice, tell the contractor this, how you receive the notice, and if you thought you didn't receive a timely notice. That's always important to mention on appeal. Next slide, please. So switching to standard appeals. Again, this is a broader category of appeals. This is an appeal to obtain coverage and payment. It's not a termination of services. It's for services already rendered. You're looking to have Medicare cover and pay for those services. In that situation, the first step, unlike being issued a notice, is the provider billing Medicare for the item or service. I have a cite to the Code of Federal Regulations here too. And I just want to note very briefly, in rare circumstances, prior authorization may be required in order to have Medicare cover and pay for services. That's more common in the Medicare Advantage context. In the traditional Medicare Advantage, Medicare context, uncommon, but for certain DME, certain ambulance transport, certain physician services, you may need to request prior authorization in order to have Medicare pay for those services subsequently. But again, comes up very rarely. Next slide, please. ABNs and demand billing. So an ABN is sort of the equivalent to the expedited notices that were discussed earlier. It is a notice that alerts a beneficiary the service they're about to receive may not be covered by Medicare. It's only required to be issued in certain circumstances. The Medicare Claims Processing Manual, Chapter 30, lays out the circumstances in which an ABN is required to be issued. Commonly, they're issued by skilled nursing facilities, home health agencies, to alert a beneficiary that Medicare may not cover the services that are going to be provided. If a beneficiary does receive an ABN, they have three options pursuant to the ABN, receive the item or service and have the provider bill Medicare, receive the item or service and agree to be liable for that item or service, or decline the item or service. Next slide, please. All right, so first step is a provider billing Medicare in the standard appeal context. Second step is beneficiary receiving a Medicare summary notice. So you're going to receive this if you have appeal rights or not. Medicare summary notices are issued quarterly, and they notify beneficiaries of all claims that have been submitted to Medicare, whether those claims were covered, and they provide denial reasons if claims aren't covered by Medicare. Linked here is a resource for beneficiaries to be able to search claims denial codes that are commonly on MSNs to kind of decipher the reason for the denial as listed on the MSN. So the MSN, like the expedited notices, lays out how a beneficiary can appeal. So that has all of the steps. The directions there should be followed. What I'm saying here is just an overview of the directions that you'll find on the MSN. Next slide, please. So you get the MSN and you have 120 days from the date of an unfavorable MSN to request redetermination. Again, there are two levels of contractor appeal: 120 days to request that first redetermination, 180 days to request reconsideration of an unfavorable redetermination, and then you have 60 days from that date of an unfavorable reconsideration to request an administrative law judge hearing. Talked previously about the benefit of requesting an ALJ hearing in the expedited context. However, it can't be overstated. The ALJ level of appeal in the standard appeal context is always worth pursuing. If you're pursuing a standard appeal, you should anticipate going to an ALJ hearing, and you shouldn't stop appealing after a contractor decision, because the ALJ hearing is frequently when decisions are overturned and when coverage and payment are granted. Beyond the ALJ, and Mary's going to talk about the ALJ level more in detail later, giving you some tips as to what to expect, how to prepare for it, and the standards for ALJs. But just the brief overview here. After the ALJ decision, you also have the right for the Medicare Appeals Council level of review. And then if there's an unfavorable Medicare Appeals Council decision, you have the right to request judicial review in federal court. Next slide, please. All right, so just some considerations in the context of standard appeals. If a provider refuses to bill Medicare, what can you do? Generally, if it's a provider that accepts Medicare, accepts Medicare payment for a service, they have an obligation to bill. But if you're struggling getting them to bill, call 1-800-Medicare. Beneficiaries have the right to generate claims themselves without the provider's help. That comes up rarely, but it's important to know if you're really struggling to get a provider to bill Medicare. And again, if a provider fails to issue the advanced beneficiary notice, the notice that a service might not be covered by Medicare, they may be found liable on appeal. So even if you didn't meet Medicare coverage criteria, the provider may be liable for payment given the fact that you weren't notified in advance that the service or item wouldn't be covered by Medicare. So again, if you're pursuing a standard appeal, Medicare Claims Processing Manual, Chapter 30, it's important to review that to determine if the provider had an obligation to issue a notice and to be able to argue for liability or a waiver of liability on appeal. Next slide, please. All right, quick review, decision types. A decision isn't always fully favorable or unfavorable. Sometimes appeal will be dismissed based on a procedural issue like lack of timeliness. Important to note, that's not necessarily the end of the road. You generally have a right to request reopening, though it's a higher bar in order to be successful with that. You have to provide good cause for why you didn't timely request an appeal. And indicate why the previous dismissal was an error. It's also possible to receive a partially favorable decision, meaning only some of what you asked to be covered is covered and paid for. In that case, you still have the right to pursue further levels of appeal. And then lastly, there's the waiver of liability, which we talked about before. Next slide, please. Finally, these last two levels of appeal, the Medicare Appeals Council and federal court. I won't go into too much detail here, but there is the citation to the Code of Federal Regulations. If that ever comes up, that will provide the general process for appealing to the Medicare Appeals Council and to federal court. And with that load of information, I'm going to turn it back over to, and this slide just has a, for visual learners like me, a chart of the process that I just discussed, broken down to standard expedited appeals, the notices that are issued, and what a favorable decision results in. So with that, I'll turn it back over to David to talk about Medicare Advantage appeals.
Great. Thank you, Eric. As folks will realize, there's a lot of overlap between these different sections. There's a lot of recurring themes. As at the outset, we talked a little bit. Now we're shifting again, just to make clear, we're now talking about Medicare Advantage appeals. At the outset, we talked a little bit about the difference between appeals and grievances. And the general bit of advice was to make sure that your intent to file an appeal is treated as such. And grievances, tend to be about expressing dissatisfaction with the aspect of Medicare Advantage plans, providers or providers' operations, activities, or behavior. Now, note that there are certain instances in which appeals and grievances are intertwined. For example, if a Medicare Advantage plan refuses to grant a request for an expedited decision, one can challenge that through the grievance process. So I want to talk a little bit about prior authorization. One thing that differentiates accessing care or services in traditional Medicare versus Medicare Advantage that Eric just touched on is that Medicare Advantage plans have the ability to use utilization management tools. That's just a fancy way of saying they can put barriers in the way of accessing services, including requiring prior authorization or pre-approval. Nearly all Medicare Advantage enrollees are subject to it, particularly for more expensive services. And the data shows that when people are denied through prior authorization, too few people appeal, but when they do, they tend to be successful. Now, while part of the justification of using prior authorization is that it can ensure that people aren't getting unnecessary or even harmful care, the flip side is that this process can prevent people from getting medically necessary care that they need, which is reflected in our experience helping people, as well as independent studies, including the one cited here from the Department of Health and Human Services, Office of Inspector General. In recent years, this has been exacerbated by plans' use of AI or algorithmic software, which again, in our experience, has led to more frequent denials and terminations of coverage. So what rules must Medicare Advantage plans follow? Under the law, they are supposed to cover all benefits available under Parts A and B, and if they offer Part D coverage, under that part of Medicare as well. In response to ongoing concerns about plans not always following the rules, in recent years, CMS has tried to narrow plans' ability to use prior authorization. For example, in the set of rules effective last year, CMS introduced requirements about whether or not Medicare Advantage plans could use rules or guidance in addition to what Medicare law, regulations, and guidance states. When Medicare rules for a given item or service is clearly established, plans are supposed to use Medicare rules only. This is supposed to apply, for example, with respect to inpatient admissions, skilled nursing facility visits, home health, inpatient rehab facilities. When Medicare rules are not clearly established, which is kind of tough for all of us to figure out when that might be, plans are able to use external guidelines as long as they are widely used and publicly available. These changes included rules about continuity of care, which are all discussed in greater detail in our report that is linked here in this slide. So far, however, there are mixed reports from both advocates and providers regarding the extent to which Medicare Advantage plans are complying with all of these new rules. So looking at the appeals process, let's start with the termination of Part A and B services. Just like traditional Medicare, as Eric outlined, Medicare Advantage has a separate appeals process when someone is receiving Part A services and the plan decides to terminate them or discharge them. That includes hospital, skilled nursing facility, home health, hospice, and comprehensive outpatient rehabilitation facilities. Similar to traditional Medicare, there's an expedited appeals process when the plan decides to end such services that are already in place. There's similar notice requirements regarding hospitalizations and in other Part A care settings. You have the important message for Medicare, you have the notice of Medicare non-coverage. If an enrollee chooses to appeal, the appeal goes outside of the Medicare Advantage plan to an outside entity, unlike the other types of appeals that we're about to discuss. The Quality Improvement Organization makes the decision in these types of appeals. If the QIO upholds the denial, there's a right to another expedited review at the next level of appeal done by the independent review entity. An important point that Eric has made and we'll try to make throughout, for expedited appeals, there are generally two levels of expedited appeals. Beyond that, getting an ALJ hearing at the third level could take weeks, if not months, and there's limited utility to going through with an ALJ hearing at that point, because in theory, what that ALJ can decide is limited to whether or not the plan's decision to end those services at the moment in time they made that decision was appropriate. In theory, they have no jurisdiction to decide about any other coverage that might have been rendered after the fact. Moving on to all other appeals in Medicare Advantage, starting with standard and then on to expedited in the next slide. Note that this applies to the range of services that are covered by a Medicare Advantage plan, including a request for coverage of Part A services that we just discussed that have not yet started. Once those services are in place, hospital, skilled nursing, home health, et cetera, and when a plan decides to terminate them, then you look at the appeals process that we discussed in the previous slide, which starts with the decision maker being outside of the plan. A decision by a Medicare Advantage plan, whether or not to cover or provide for an item or service, is called an organization determination. An MA enrollee has a right to ask for one, including in advance of receiving services. If the plan decision is adverse to an enrollee, then that triggers a right to appeal, and that individual can request the first stage in the appeals process, a reconsideration, which goes back to the plan itself. So they have another chance at deciding whether or not their first decision was appropriate or not. Standard reconsideration, plan has 30 days, 60 days if it's regarding payment for services already provided. If the plan upholds its own denial, then the appeal is automatically sent to the second level of appeal called reconsideration, which is conducted by the independent review entity. And if that entity upholds its appeal, upholds the denial rather, the individual has a right to request an ALJ hearing. Note that in these different appeal scenarios, A Medicare Advantage organization can sometimes delay the time frame if requested by the enrollee, or if the extension is justified due to exigent circumstances that are in the enrollee's best interest. So we talked about expedited appeals regarding termination of services in certain care settings covered by Part A. We just touched on standard appeals in Medicare Advantage for all other services and scenarios that are triggered by an organization determination. And now we're going to touch on expedited appeals. An enrollee or physician can request an MA organization to speed up, to expedite their decision-making process, to issue an expedited organization determination as to whether or not the plan will provide or cover or continue services. Note that there is no right to an expedited organization determination of requests for payment of services that have already been furnished. If a plan makes an expedited organization determination that decides against the beneficiary, the individual can request an expedited decision at the first level of appeal, which again goes back to the plan. It's known as reconsideration. The plan gets another opportunity to decide if their first decision was correct or not. As the previous slide noted, they have 72 hours for an expedited organization determination. And similar to a standard appeal, if the plan upholds its own denial, it automatically sends the case to the independent review entity, which is the second level of appeal. If that entity upholds that appeal, then there is the right to administrative law judge hearing. But remember, there's usually limited benefit in pursuing the appeal further to the ALJ if services have not already been rendered. A beneficiary can request an expedited appeal if applying the standard decision procedures could seriously jeopardize the life and health of the enrollee or the enrollee's ability to regain maximum function. But the plan can deny that. If a physician, regardless of whether or not that physician has a relationship or contract with the Medicare Advantage plan, makes a request for an expedited appeal, the plan under the regulations must comply and must expedite that decision-making. Unfortunately, though, we hear from our provider partners that even when physicians request expedited appeals, they are not always honored by the plan. Here's a slide with some more resources, some Code of Federal Regulations sites, as well as Medicare Part C and D enrollee grievance organization and coverage determinations and appeal guidance. We'll now turn it over to Justin for Part D appeals. Justin.
Thank you, David. So I will be going over Part D appeals. Part D is the prescription drug benefit under Medicare, for those of you that don't know. And essentially, I'm going to be focusing on what makes it different, or what is unique about the Part D prescription drug appeal process compared to the other areas of Medicare. This slide, I'm just reminding folks that there are two tools in the advocacy toolbox. One is the appeal and one is the grievance. But an appeal has to do with a drug denial, that the coverage is being denied. Grievances have to do with anything else, such as poor customer service. An issue with the appeal process itself can be complained about in a formal grievance. But if your appeal has to do with the denial of a drug, you need to use the formal process of an appeal rather than the grievance, where you're essentially making a formal customer service complaint. Next slide, please. So in the Part D realm, the appeals start with what's called an exception request. So you're asking for an exception to the rule, and the rule either has to do with the drug being on the list of covered drugs for the plan, or whether the co-payment costs for the drugs are too high compared to other drugs that may work usually in the situation. So for example, for the first type of appeal, which are called formulary exceptions, that has to do with the decision to either have the drug off their list of covered drugs or have a particular utilization requirement, such as prior authorization, which means they need the doctor to justify the prescription before they are willing to fill it. Quantity limits, for example, keeping it when each fill is at a very low level to prevent abuse of a drug, or step therapy requirements, which require a beneficiary to try a different, cheaper drug first. And then once it fails, you get to have coverage of the drug in question. So before, and essentially to get this process started, you need to get the plan's decision in writing. That's called the organization determination. You need to get something from the plan in writing. It can't just be the pharmacy saying this drug isn't covered by your plan. It needs to have all of the information about why they are denying the drug, and that they're required to give that to you in writing. It's just a matter of going through the process to get that organization determination. Next slide, please. So I talked a little bit about formulary exceptions. These are the two main appeal areas in Part D. So a formulary exception has to do with your drug not being covered by the plan, or waiving those utilization management tools that I discussed, prior authorization, step therapy, et cetera. However, there's another type of appeal called a tier exception, where essentially you're saying that the copay for your drug is too high. What these plans do is they have tiers of copayments. So tier 1, for example, could be generics that don't cost very much, and they are essentially free in most plans. And then go up to higher levels of cost sharing, tiers 2, 3, 4, 5, sometimes tier 6 drugs that, and at each level, the copayments get higher and higher, sometimes at the highest levels being a large percentage of the drug as coinsurance. It's important for both of these appeals to be very familiar with your drug plan's EOC, or evidence of coverage. That EOC is the rules for the drug plan across the board. They have to explain their exceptions process, like when do they approve formulary exceptions, what are the rules for their tier exceptions. So getting a copy of that EOC and reading it thoroughly to understand their appeals process is a major part of any Part D appeal. Next slide, please. That being said, my practical advice for dealing with Part D appeals essentially is 2 steps. It's requesting information and then doing as much research as you can to prepare your appeal. So you'll be requesting relevant medical records from the prescribing physician, including progress notes, any prior authorization attempts that that physician made, even old progress notes having to do with maybe years old, having to do with any relevant medical history, or any previous prescriptions that have failed already. We tried this prescription already a few years ago and it did not work for me. And my doctor knows that, and that's why we're asking for an exception here. Those are all relevant pieces of information for your appeal, depending on which type of appeal you're bringing. And then I would say the research aspect of this before you do anything is extremely important. When I take a case, I try to learn as much as I can about the drug and why it's being used for the beneficiary in that case. That usually involves me reviewing those progress notes, reviewing the physician's opinion, looking up the drug plan's evidence of coverage and their drug formulary to understand how the plan covers different tiers of drugs, and when they approve exceptions, what their rules for tier exceptions, for example, or formulary exceptions are. Next slide, please. So one last thing that I'll be going over for both formulary and tier exceptions is the physician statement. So both types of Part D appeals require that the prescribing physician submit a formal statement about why the drug exception should be approved. So if it's a formulary exception and the drug isn't on their list of covered drugs, why do you need that drug? Why will alternatives not be as effective or not be safe for this patient. And the physician has to give their statement in writing for a formulary appeal. My summary of that rule, once again, is the physician just has to say that it's not as effective or it will have adverse effects for some reason having to do with the patient's medical history. Next slide, please. Tiering exceptions are the same. You require a physician statement. Once again, you have to say that the alternatives at lower tiers of cost sharing, so cheaper generic drugs typically, you have to be able to show why those won't be effective or will have adverse effects if you're using those cheaper drugs. So more expensive, if you're trying to justify having the more expensive drug brought down to a lower level of cost sharing, you have to be able to justify through the physician's statement why that is the only thing that's going to work in this particular patient's case. Next slide, please. While the appeal is pending, the plan is not required to give you coverage. When your new plan begins, whenever that may be, you can get a transition fill of 30 days for a drug, but the plan isn't required to continue giving the drug past that point, even though you may have an appeal pending. So as a practical matter in these cases, you have to figure out what I call bridge coverage, just what can keep the drug covered for this patient or as cheap as possible while the appeal for the drug is pending before the plan. So some good resources outside of the legal process are Cost Plus Drugs, GoodRx. Certain drug manufacturers have their own patient access programs. It's good to investigate all of those while you're getting the appeal together, just as a practical way for the patient to continue getting their drug. Next slide, please. Even if the exception is granted, the plan is only required to have it in effect for that plan year. They do sometimes continue it past that plan year, but they're not required to. So it's important as you reach the end of the plan year for the patient to consider moving into a different plan where the drug is on the formulary, the coverage is guaranteed, or the cost sharing is more reasonable than the current plan that you're in if it's a tier exception. Once again, reading the evidence of coverage is huge, both for any plan that you're in and getting drug coverage or any plan that you're considering to enrollment in. Next slide, please. So once the plan denies your exception, then you start going through the Part D appeals process. I won't walk through this since we've already gone through it, but essentially it follows the same 5-step process that Eric and David went over earlier. Next slide, please. One last practical thing that I wanted to talk about is enforcement of favorable decisions. So OMHA, which is the administrative law judge level, and the other levels of appeal contractors, they don't enforce their own decisions. They don't go out and make sure that the plans are doing what they said to do. Their manual's advice, the ALJ's manual's advice, is that you contact Medicare to get the decision effectuated. In my practice, it's kind of across the board, just doing whatever you can to get the plan's attention. That includes calling customer service, to show them the favorable decision. Hey, I got coverage in this case, or this judge ruled in my favor, and I need you to fix the cost sharing for my drug and give me a refund. If that doesn't work, if direct contact with the plan doesn't work, then I expand it to CMS, either contacting a regional office or filing a formal grievance with the plan. The reason I mention this is because across Medicare appeals that I've done, Part D, the prescription drug appeals that I do are, for whatever reason, I've had a really hard time around getting plans to actually do what they're ordered to do. So I highlight that for Part D appeals in particular. I'm not really sure why plans have such a hard time listening to the legal decisions that I get for patients. So. All right, next slide. I think that is the end of my section. Here are some resources for everybody. These are the CMS guidelines for this prescription drug benefit, the regulations, and then just a reminder that you should look up the evidence of coverage and the other drug plan information online. And I'll pass it over to Mary.
Great. Thank you, Justin. So my name is Mary Ashkar. I'm a senior attorney here at the center, and I'm going to talk a little bit about appeal tips based on our experience doing hearings. And also I'll talk a little bit more about the administrative law judge or ALJ level of review. So this first tip seems a little bit obvious, but it is critical to keep your eye on the deadlines. At each level of the appeals process, you will get a decision, and that decision will have instructions on how to appeal to the next level. You should make sure that you're following all of those directions closely, also making sure to keep a copy of everything that you send with your appeal. So what happens if you miss an appeal deadline? That does happen. You might still be able to appeal if you can allege what's called good cause. Good cause examples are set forth in the regulations. They include, for example, if you can show that you did not receive a previous decision, you were prevented by a serious illness, or maybe even a death in your family prevented you from submitting a timely appeal. But the bottom line is it's very important to make sure that you're appealing in a timely manner. We have made good cause arguments on people's behalf. We have both been successful with those arguments. We've also seen them be rejected. So bottom line is you want to make sure that you are appealing timely. Next slide. So immediately after you learn that your service is going to be denied by Medicare, you should start building your case. You can and should do everything that's on this slide. So the first thing you want to do is read that decision very carefully to understand why the claim was denied. Second, you should be gathering all of the medical records, and you really want to think through which providers have those relevant medical records. It might not just be one. So for example, if you're appealing a denial of your skilled nursing facility coverage, you might want to get records both from the SNF as well as possibly the hospital that you were at prior to being discharged to the skilled nursing facility. 3, your argument should be constructed in the form of a narrative. So you should tell the story about yourself or the person that you're helping, what was happening possibly prior to the services, why the services were medically necessary, and why they continue to be necessary. And you can certainly send a narrative, or you can send a statement, a very informal statement along with your appeal. It is helpful to enlist the help of the community physician or even the doctor who is ordering the services. It's best to get them to put something in writing, explaining why the services were medically reasonable and necessary. And here I want to flag our website. We do have some self-help documents that include sample doctor's letters that a doctor could complete to support somebody's appeal. You also want to collect and submit supporting medical research if that's helpful to your claim. And then finally, and Eric mentioned this, the 3 important legal resources that you want to make sure that you're familiar with prior to doing the appeal: the regulations, the policy, and there could also be applicable national and local coverage determinations. But you want to make sure that you arm yourself with the relevant law. Next slide. So now let's assume that your appeal has reached an ALJ level of review. How should you prepare and do the administrative law judge hearing? Somebody put this in the questions, I think. We need an explanation of all the initials. Yes. So let me start off by talking about the big initials that I'm going to be referring to. ALJ is the administrative law judge. That is the judge who presides over the administrative hearings that are de novo hearings. The other acronym that you'll hear me refer to is OMHA. That is the Office of Medicare Hearings and Appeals. That is the office that administers the nationwide hearing program for Medicare. There is a central office as well as 10 field offices. So those are the 2 big acronyms you'll hear me refer to. But prior to an ALJ hearing, you will receive a notice of hearing in the mail. It will be sent to you 20 days prior to when the hearing is going to be scheduled. You should look at this very closely. It will tell you the time and place of the hearing, how to call into the hearing, who the judge is that's been assigned to the case, and sometimes most importantly, the legal assistant, if you need to reach them for any reason prior to the hearing. But you can use this opportunity if you are unable to appear at that time. You can certainly object to the time and place of hearing. I would say that one very critical step prior to the hearing is to get a copy of both the exhibit list as well as a copy of the OMHA case file prior to the hearing. One of the most helpful things I found when doing hearings in front of judges is being able to point to exactly what the judge has in front of them. I had a hearing yesterday where the judge said that they were going to pause and take time to find everything I was referring to in the record. So it's very important. And sometimes when you do get a favorable decision, you'll see that they've actually cited to the places that you have specifically pointed out in the record to them. And you do have a right to get a copy of the administrative record prior to the hearing. And finally, it is okay to supplement your case file prior to the hearing. So once you get a copy of that record, if you see that something very critical is missing, you do have a right to send that to the judge. You can just send the records. You can send it again along with a supporting statement. It does not have to be very formal, but it should be well organized, clear, and very detailed if you're going to send something to the judge. Next slide. So let's move on to arguing the case in front of an ALJ. First, it is important to know that the process is very informal. The procedures are very relaxed. As a matter of fact, the regulations specifically say that an ALJ may receive evidence at the hearing, even though the evidence is not admissible in court under the rules of evidence. So the format of the hearing is usually, it is a very informal process. Usually they will let the appellant go first to present their case, and then they'll let anybody else on the call participate. So if a provider is there, they'll go second. The most formal I've ever had a judge be is they've asked me if I have an opening statement and then an argument and a closing statement. But typically the judges will just let you present your case in the narrative form that you feel is most helpful to your case. And then they'll ask questions at the end. But it is a very informal process. At the beginning of the hearing, the judge will ask if you have any objections to the exhibits before entering them into the record. This is the time to make sure that if you have submitted anything in addition to the record, make sure that it is admitted as part of the administrative record. So if it's not on the exhibit list and you sent it in, you want to make sure, say, Your Honor, I just want to make sure that you received my additional records and I ask that they be admitted into evidence at this time. And the judge also at the very beginning of the hearing will swear everybody in. Sometimes they do swear in attorneys, but usually attorneys do not get sworn in. And then also make sure that during your argument, you're citing to the relevant, we've talked about this multiple times, but I cannot stress how important this is to have the relevant regulations and policy manual in front of you. You want to be armed with that before you go into the hearing. Not everybody knows the law. Not everybody follows the law. Sometimes we've seen people make up the law. Most recently, I had a contractor come to the hearing and say, yes, I understand the law, but I don't agree with the law. That is not okay. So it's very important to be able to point back to what the law says, and you say to the judge, here is exactly what the law says. And also ALJs are bound by the laws and regulations pertaining to the Medicare program. So they can't ignore it. But don't be surprised if people come to the hearing and say things that are not correct, but be prepared for that. And then also when citing the law, and David mentioned this, with very few exceptions, Medicare Advantage plans are required to cover or make payment for all those services that are covered by Medicare Part A and Part B. Next slide. Okay, so continuing with just tips on how to argue a case in front of a judge, each party again is going to be given the opportunity to present their case via oral argument. It may be helpful to have the client testify, or if you're doing your own appeal, you can make a statement on your own behalf, or even have a family member that's close to the situation provide testimony if that would be helpful. Prior to doing the hearing, this is another big tip. I always assume, even if I have sent in a brief, if I've sent in additional records, or even just the records just exist in the case, I do not assume that the judge has reviewed anything. I prepare my case and I prepare the argument as if the judge is just laying a fresh set of eyes on everything that's in front of them. I've seen sometimes people start to testify and start to tell their story, and they just jump right in. They'll, if somebody's receiving therapy services, they'll just immediately start talking about the therapy services they're receiving. And I always say, try to tell the story. So if that person was receiving therapy services in the skilled nursing facility, you might start all the way back to when they were living at home prior to their hospital stay. So this is what my condition was prior to me being hospitalized. Then I was hospitalized for this. Then I was discharged to the skilled nursing facility where I started receiving therapy services. I was told they were going to end. This is why I feel like they need to continue, because I'm trying to get back to that place I was at where I was living independently and didn't need this level of assistance while living at home. So again, assume nothing, tell the whole story. The judge will ask you questions afterwards. And sometimes the judge will even start the hearing and say, I've read your brief, or, I've read everything, and then you can decide how you want to proceed from there. But I always start off the hearing assuming that they have not reviewed anything. You can definitely rely on medical experts during your hearing, any kind of statements, medical text, other medical research. While I mentioned that these are very informal hearings, you are given the opportunity to cross-examine any parties who are arguing against you. So for example, we do have Medicare Advantage plans that sometimes come and they bring their medical director and they testify. If they are listed as a witness, the medical director, you want to make sure that you find out everything that you can about their background, whether they treated the beneficiary, whether they read the person's case file prior to the hearing. These all sound very obvious, but we have had doctors come to our skilled nursing facility cases where we have elderly patients who are pediatricians. That is their specialty. We have had doctors come and testify who have not read the case file. Almost never have the medical directors physically treated the beneficiary, and judges will take note of that. We had a judge who ruled in our favor. They did find it significant that the doctor had not treated the beneficiary, conducted any tests on the beneficiary, and they did point out in the decision that the doctor was not a neutral, uninterested witness, and they noted specifically that all of these things go to the credibility of the witness. So it is okay to point those things out during a hearing. Next slide. So getting a timely decision, if you're not getting a decision in a timely manner, I believe that once you've requested a hearing, the judge has 90 days to issue a decision from the date of the request. You can call 1-800-MEDICARE or call the Medicare Advantage plan. Also, there is an entire page on OMHA's website that talks about beneficiary appeals. Basically, that those appeals are supposed to go to the front of the line. So when you're filing an appeal for a beneficiary, you should put the following in the address: attention, beneficiary, mail stop. There is also a beneficiary helpline that's specifically for beneficiaries or representatives of beneficiaries who are filing appeals. You can call that number, that OMHA number, to get assistance. And then next slide. So the most important, I think is the most important appeal tip, is do not give up. We have found over the years that there is very little coverage granted at the lower levels of review. This is probably because most of those reviews are paper reviews. It is not until you get in front of an administrative law judge that you can make your case and you can actually have a conversation with another person, a judge, about your case and why you think the services should be covered by Medicare. So it is very important to not give up, to not get overwhelmed, and to not necessarily think that just because you read a decision that says it's not skilled and doesn't meet the coverage criteria, that you shouldn't go forward. We see the law being misstated or not applied correctly all the time. So do not give up. And then the last slide that I have has the resources. So I've referred a lot to Office of Medicare Hearings and Appeals, their website that gives, I know we've had a lot of questions in the chat about different, it does talk about the different levels of review, timelines for submitting appeals. It also has forms on their website. And then finally, if you're still feeling a little anxious about going to an administrative law judge hearing, I would encourage you to go to the second link, which is the Office of Medicare Hearings and Appeals, their case processing manual. This sets forth the day-to-day procedures for how the judges do hearings, and they actually give like paragraphs, narrative paragraphs of what the judges are supposed to say during hearings, and it is exactly what the judges say during hearings. So if you read through that, there will be very little surprise as to what the judge is going to say during the hearing, how they're going to conduct their hearings, and what that actually looks like. So it's a great resource for that. And I think that's it. I'll turn it over to Wey-Wey.
Hey, hi there, everyone. Well, certain Medicare beneficiaries who are negatively impacted by being placed on hospital observation status now have an appeals process, which I will discuss pretty quickly because I want to make sure that we can get to the questions that you all have put in the chat line. So one of the problems of being put on observation status is that a patient might not qualify for a covered stay in a nursing facility after they leave the hospital. And that's because Medicare requires a 3-day inpatient hospitalization billed to Part A as a prerequisite for nursing home coverage. Time spent in observation status, however, is technically outpatient and billed to Part B, and it does not count towards those 3 inpatient days. So as the examples on this slide illustrate, a person could spend 3 or more days in the hospital, but if they weren't classified as inpatient for at least 3 days, then they don't qualify for Part A nursing facility coverage. Another problem is that beneficiaries who are not enrolled in Part B could bear the full sticker price for their hospital stay if they're put on observation. Now, historically, Medicare did not allow patients to appeal these status designations. Consequently, many patients had no recourse but to pay thousands of dollars out of pocket for rehabilitation care they needed in a nursing facility, or they had to go without that care. Next slide, please. In 2011, we brought a federal class action challenging Medicare's failure to allow patients to appeal their observation status classification. After years of litigation, the judge in that case decided that patients who are initially admitted as an inpatient by a doctor, but then reclassified by the hospital as observation, are constitutionally entitled to due process. The decision ordered Medicare to create an appeals process for those who were harmed in the past, as well as an appeals process going forward. Next slide, please. So the prospective appeals process became operational last month on February 14th. These appeals are permanently available to eligible Medicare beneficiaries who disagree with a hospital's decision to reclassify them from inpatient to observation. Hospitals are now required to give these patients notice about the status change while they are still in the hospital. If a patient disagrees, they can request an expedited or fast appeal before they leave the hospital. And if they win their fast appeal, they'll know sooner whether they meet the 3-day inpatient hospital stay requirement to qualify for nursing home coverage. In addition to these expedited or fast appeals, a standard appeals process will also be available. Next slide, please. So to be eligible for this particular appeal, a person must be in traditional or original Medicare, not a Medicare Advantage plan. The person must also be admitted to the hospital as an inpatient, but then later switched to outpatient receiving observation services. Additionally, the patient either needs to have spent 3 or more consecutive days in the hospital, but classified as an inpatient for fewer than 3 days, or else they have to be someone who is not enrolled in Part B coverage. Next slide, please. CMS has developed a standardized notice called the Medicare Change of Status Notice that hospitals must now issue to beneficiaries after they become eligible to appeal. This notice informs them that their status has been changed to observation and that their hospital stay will be billed to Medicare Part B instead of Part A. It lets them know that this change could impact their hospital bill, since under Part B, they'll have a 20% copay for their hospital services. Now, keep in mind that someone who has a Medigap supplemental policy that covers their Part B cost sharing may not feel any impact at all on their hospital bill. The notice also informs that if they don't have Part B, then they will be charged the full cost of their hospital stay. And then also that the status change means that Medicare will not pay for their skilled nursing home stay after leaving the hospital. And finally, the notice provides information about their appeal rights and how to appeal to a QIO. Next slide, please. Now, if the patient wants to appeal the status change, they should request an expedited determination from the QIO before they're released from the hospital. In turn, the QIO must examine the medical records, solicit the views of the patient or their representative, and also the hospital. Then it must notify the patient of its decision within 1 calendar day. And the QIO's decision will be binding on the hospital and the patient unless the patient is dissatisfied and appeals to the next level. Next slide, please. If the patient requests an expedited reconsideration from the QIO by the noon of the following day, the QIO then has 2 calendar days to render a reconsideration decision. If that decision is unfavorable to the patient, they have a right to request an ALJ hearing. Now, it should be noted that patients are not shielded from financial liability while pursuing these expedited appeals challenging their status change. Next slide. So I've mentioned expedited appeals, but what if an eligible patient did not appeal before they left the hospital? So under the new regulations, an eligible beneficiary can initiate a standard or untimely appeal request with the QIO at any time. So even if they're already in a nursing home or even after they've left the nursing home, they can do that. Now, QIOs do have a slightly longer time frame to issue a decision and a reconsideration in that situation. Now, after the reconsideration level, the regulatory timeframes for standard Medicare appeals apply at the next 3 levels of a review. Next slide, please. So beneficiaries can appoint an authorized representative to assist them in these and other appeals. And we've added here a link to the appointment of representative form that they need to submit. Now, some representatives are already authorized, such as a person's rep payee, their guardian, or a power of attorney, but they may need to furnish proof of that relationship. Providers are not allowed to represent beneficiaries in these observation status appeals. They can, however, assist them in navigating the process and by furnishing records. Next slide, please. So what criteria will be applied to these appeals to decide if someone was entitled to inpatient coverage? Well, the QIO and other reviewers will want to verify that there was an inpatient order showing that a doctor initially admitted the person to the hospital as an inpatient. And the next crucial inquiry is whether the 2 midnight rule was satisfied. So under Medicare policy, inpatient coverage is generally appropriate if there was a reasonable expectation at the time of admission that the person needed medically necessary hospital care crossing at least 2 midnights. So the reviewer in these appeals should determine if the physician's expectation was reasonable based on what was known about the patient's medical condition at the time of admission. Next slide, please. Now, if somebody was affected by this issue in the past, for hospitalizations going back to 2009, they can file a retrospective appeal. The eligibility requirements are mostly the same as for the prospective appeals. Next slide, please. To initiate a retrospective appeal, they will need to submit a request to the eligibility contractor and provide certain information demonstrating their eligibility. They will need to do this, though, by January 2nd of next year, although they could seek a good cause exception if they miss this deadline. Next slide, please. So for anyone who is interested in more information, we have a link to a resource page that includes a recorded webinar that focuses on these observation status appeals, much more information on how to go about it, as well as a step-by-step flow charts for these two appeals processes. And with that, we will go on to questions and discussion. Thanks.
Thanks, Wey. Let's pull all of our panelists back up here. And rather than this boring questions and discussion slide, why don't you kick it over to the last slide so that people know how to contact us if they want more. Thanks. We absolutely have questions, dozens and dozens of questions. And I want to thank Justin, who I don't see, who has been jumping in there and answering them, and Mary as well. Really appreciate that. I've glommed a couple of thematic things together here as well. For example, Norm asked, aren't the first two steps in this appeals process kind of asking the same person to make a new decision on what they already denied? And is that necessary? And Mark asks, why are there 5 levels? Are they necessary?
I'll start. Thank you for the questions. We have long thought that the first, I think Mary might have referenced this, the first couple of stages of appeals in general is pretty duplicative and often upholds an initial denial. So if we had our druthers, we would eliminate 1, if not 2, of the levels of appeal. Now, as far as the decision going back to the decision maker on the part of MA plans, at least for Medicare Advantage, so few people actually appeal denials, but when they do, they have a very high success rate. So it's something like, say someone is denied something through prior authorization, is the type of appeal that goes back to the Medicare Advantage plan. Roughly 11% of people bother to appeal such prior authorization denials, but of those who do appeal, over 80% tend to be successful, which suggests that Medicare Advantage plans perhaps are being overly restrictive in the application of prior authorization. I don't know if anyone else has anything else to add to that.
Currently not. Thanks, David. We had a couple questions. I think this might just need clarification on appeals in Medicare supplemental plans. I'm not sure if they really meant Medigap or if they were talking about MA. So maybe you could reiterate appeals similarities, differences in MA, and whether there's anything to do with Medigap plans.
Sure. So Medicare supplemental insurance plans, often known as Medigap plans, are standardized plans lettered by the number of the letter of the alphabet. So you know what benefits you're going to get based upon the letter of plan that you purchase. These are designed to go along with traditional original Medicare and fill in some of the cost sharing and some coverage. There are no appeals processes that apply to Medigap plans because they make no decisions about coverage. If Medicare covers something that they're responsible for paying cost sharing for, they're supposed to cover it. If Medicare denies something that that would be covered under Medicare, normally the Medigap plan isn't obligated to pay anything. Now, some Medigap plans offer some extra bells and whistles, which is completely outside of this process. But in general, there are no appeal rights associated with Medigap plans.
All right. Thanks again, David. We had a couple questions that touched on something near and dear to a lot of us, the JIMO settlement. And I see that it looks like Justin grabbed one of those. But basically, it boils down to two directions in the question. One, is the Jimmo settlement considered when these appeals are made? Two, we are making appeals and we're finding that Jimmo is not being considered. What can we do?
Anyone else want to take a crack, or should I jump in again? Well, Jimmo is the law of the land. It is supposed to be followed by providers, by Medicare contractors, by Medicare Advantage plans. Jimmo, of course, stands for the proposition that someone need not improve in their functional status in order for medically necessary therapy or nursing services to be covered in certain care settings, skilled nursing facility, home health, outpatient, to a lesser extent, inpatient rehab facilities. It has been our experience now well over 10 years since that settlement was reached with the Department of Health and Human Services that too many providers are still unaware of it. Too many contractors are not following it. We always argue it if it is relevant to the appeal, and it should be followed. We do have a wealth of information on our website, self-help packets that address denials of care in different care settings, including through a Jimmo lens, and trying to ascertain whether or not there may have been an inappropriate denial or termination based upon an application of an inappropriate improvement standard. Anything else any of my learned colleagues want to add?
Yeah, we definitely raise it at the ALJ hearing level, and we do often see it, mentioned in the ALJ decisions, whether they considered it or not. And, it's important, if you're able to, if it's an unfavorable, to appeal to the next level, and raise the, what if you believe that they didn't adequately consider Jimmo in their decision.
Thank you both. We had a couple folks ask about continuation of services / discharge while services are under review. Are providers required to continue the services while they're being appealed?
I can start off on this one, and then if anybody
Mhm.
has anything to add, feel free to jump in. It's situation specific. In the hospital context, it's a really good question. At the first level of appeal, that BFCC QIO determination, you can't be discharged prior to the BFCC QIO making their decision. After that, you can't be billed for services while awaiting the reconsideration decision. So that decision that's required to be issued within 72 hours. There were some related questions I saw in the chat about how far in advance the IM has to be issued. And there is CMS guidance that 4 hours prior to discharge, the notice must be issued. But as I just said, if it's given to you 4 hours prior to anticipated discharge, you're appealing that. You can't be discharged until the BFCC QIO renders their decision.
Thanks, Eric. Anything else? All righty. We have several questions on observation status. And of course, we always get this one. Why? Why do they do that?
Why do hospitals place beneficiaries on observation status?
Yep.
Okay, well, it's a different classification of a beneficiary who may not, they believe may not need to be admitted. So it's a period where they may be getting certain services from the hospital and monitoring before deciding whether or not they should need to be admitted to the hospital or whether they can be just discharged home. So, right. I think more and more we're seeing patients being placed on observation status, and then and there might be some pressure on doctors as well to, by the hospitals to place patients on observation status rather than on inpatient, even though, the payment from Medicare is different, on that basis, and not necessarily better for the hospital if the patient's on observation. But there's just been so much, I guess, pressure, and we believe pressure from Medicare to, ensure that there's more, I guess, payment wise, there's worry that hospitals are worried that they will be audited if, patients are on inpatient status when they may not need to be, when they may not be meeting that medically reasonable standard for inpatient care. But I mean, one thing, they tried to make it less confusing by having this 2-day, the 2 midnight rule. That's supposed to help, so that, doctors really know that, when they feel like a patient is going to need hospital care over 2 midnights, to actually treat the patient's illness or injury, that they could safely, order them as an inpatient. But it hasn't necessarily worked out that, to help that much.
Thanks, Wey. We had a question on actually attending a hearing. Paul wanted to know, telephone or video hearing, what's better? Can you even get a video hearing nowadays?
I can answer that. So the regulations, I believe if it's an unrepresented beneficiary, then I believe that the law says that the judge is to direct that it be conducted by video teleconference. Anybody other than an unrepresented beneficiary, they will direct that it is via telephone. So unrepresented beneficiaries, I believe, can have a VTC hearing, so they can see the judge. That's certainly an option. I think that we have found, and maybe others can speak to this as well, that a lot of the times when we are representing beneficiaries and we say, well, we might be able to fight for a VTC hearing, oftentimes they prefer to have the telephone hearing. But yes, VTC can be an option for unrepresented beneficiaries.
Excellent. Thank you very much. Similarly, you talked about submitting evidence, and some of these questions may have been answered in the chat. I'm not super sure. We had someone say that they were told that they could not, in fact, submit evidence at the ALJ level. And I think this might have been a provider side appeal. They were told it had to be submitted at the prior level. Is that accurate?
Yes.
Okay.
I think I answered that one in the Q&A. So I believe it's 42 CFR section 405.1018 that talks about the submission of additional records. And yes, there's different standards if it's a provider that's trying to get records into the administrative record prior to the hearing. So beneficiaries, there's a different standard, and they are able to do that.
Thank you very much. I had one other question on timeframes. I'm not sure if it got answered here. The gist of it was that they were told by the contractor that it would take 60 days for a doctor to review their appeal. So there's no way they were making that 72-hour time frame to get an answer. What can they do in that case?
That
Can
was
someone
it
answer that
in the
one?
context of an expedited appeal.
Yeah. Yep.
Yeah, that shouldn't be happening. 60 days for a contractor to decide an expedited appeal shouldn't be happening. I've never heard it taking that long. I do believe there's a procedure to skip right to an ALJ hearing, but again, there's a time issue when it comes to the scheduling of the ALJ hearing. So I would be in contact with the contractor again. Again, I haven't heard of that happening, but they are obligated to issue the decision within 72 hours.
Thanks, Eric. We have, we're a little bit over. Do we have any closing comments from our panel? I don't think we have any other themes that we haven't touched on at least a little bit here. So we do have dozens of questions outstanding.
We appreciate everyone's time and attendance. We know this is complex, needlessly so. A lot of information. Hopefully the resources that we provided will help you parse through some of that. We are available to the extent we can be as a resource. But I think the overall message is, as Mary said, don't give up. And if you feel that you are entitled and eligible for services, or you're helping someone that is, we encourage you to fight for what you should be getting through Medicare, and don't let denials intimidate you.
Thanks, David. And we had a lot of great SHIP volunteers on this webinar today, so I encourage you to use your local SHIP program if you can. They're fantastic. And of course, in Connecticut, you can call us here at the center. Thanks everyone who attended today. As noted earlier, you'll be receiving a follow-up email from me. It'll have links to the recording. It'll have a copy of the slides. I'll see about chat and questions as well. And of course, stay tuned for future programs, including our soon upcoming National Voices of Medicare Summit, May 14th. Registration now open at medicareadvocacy.org/summit. You can attend virtually. So very easy. Please go sign up. Thank you all again, and I'll now conclude today's presentation. Thanks very much to our fine presenters.
Thank you.